And so maybe now the future is predicting hypertension before it actually happens to patients. Why use the arterial waveform to detect hypertension? Well, beyond the obvious, it measures blood pressure. The arterial waveform gives us huge amounts of information about the cardiovascular system. The systolic rise time tells us about contractility. Systolic decay time gives us information about large vessel compliance. The diastolic time tells us about peripheral effects. We can measure heart rate. We can measure stroke volume. And overall, from an arterial waveform, we can extract 160 different features. But none of those features will tell us about hypotension or the likelihood of hypertension. And why would they? They are static features at a single point in time. But in terms of the algorithm and how it's derived, it's not just based on these absolute waveform features. It's based on how these features interact. The information is not just used on its own merits, but in terms of the variability of these biological parameters, their complexity, and their links and interactions, as well as combinatorial factors. In terms of variability, heart rate, cardiac output varies naturally. When we sit there with a heart rate of 60, it isn't really 60. It's 61 seconds, it's 62 the next, it's 58 the next. There is beat-to-beat variability, and the average of that is 60 beats per minute. As a state of instability, such as hypertension, occurs, then biological variability decreases, and this can be quantified. In addition, the complexity of the arterial waveform signal is also lost as we approach instability. Indeed, the complexity of lots of variables change. We see this every day. If we see a fit, healthy patient in theatre, they have a very well-defined arterial waveform, a very clear dichrotic notch, a nice peak to the waveform itself. As patients become unwell, these waveforms tend to become slightly more featureless. They lose their complexity. And we can measure that complexity or loss of complexity through a process using entropy. And also from the arterial waveform, we can look at physiological links, the interaction between stroke volume, mean arterial pressure, heart rate, etc., and how they change in relation to each other, particularly focusing on the baroreceptor reflexes. And when we do that, what we can do is extract 3,000 waveform features from each individual waveform. And this is where the machine learning process starts to analyze these large amounts of data. First of all, we do ROC analysis to find the best predicting factors or variables for hypotension. And then what we do is use combinatorial permutations. We take the 51 best predicting features and we multiply them by each other at various powers ranging from -2 to +2. What this gives us for each arterial waveform is over 2.5 million features. And this is what goes into machine learning algorithm through a process called performance analysis and sequential feature selection. What we come out is 23 of the most predictive features for hypotension. And for full details of that, please do read the excellent validation paper in anesthesiology by Faraz Hatib and Maxine Caniston. So what you end up with is an algorithm in a box. And what you get is a number, the hypotension prediction index, and also additional parameters to help us treat hypertension, such as EA-dyne and DP-DT, that we'll look at a bit later on. So what you get is not a mystery number from a box, but the output from a very complex algorithm derived from millions of features and vast amounts of data points that is used to predict the likelihood of hypotension. And this is the hypotension prediction index. So what is hypotension prediction index, or HPI? Well, HPI is a number that relates to the likelihood of trending towards a hypotensive event. Now, a hypotensive event is defined as a mean arterial pressure of less than 65 millimeters of mercury for greater than 1 minute. The higher the number, the higher the likelihood of a hypotensive event occurring, and the shorter the timescale it happening. The lower the number, the less likely a hypotensive event is to occur. And if it does happen, it happens much, much further into the future. This is data from our hospital from one of the papers we published on the subject. And we can see here if HPI is between, say, 2029, then round about a third of patients will become hypotensive moving forward. Now, on the face of it, that sounds quite bad. But as these patients approach hypertension, the HPI will increase. And if hypertension does occur, it's around about 8 to 9 minutes in the future. Whereas if HPI is raised at 90 to 99, almost all patients will be hypotensive, and the time to hypertension is greatly reduced. In this instance, the median time is 2.3 minutes. So the higher the number, the more likely hypertension is to occur, and the shorter the time scale to its occurring, and vice versa. And the whole premise of this is that you can intervene. This is data from a patient having an open anterior resection. The black line is our HPI, the red line is our mean arterial pressure. We can see that HPI crosses the threshold of 85, and we use 85 as a cutoff because at this point the positive predictive value is very high, and we don't see hypertension for almost 7 minutes later. And the whole premise is that in this interim period, we can look at the underlying physiology, find out what the cause or likely cause of hypertension is going to be, and treat it before hypertension happens, avoiding those repeated dips that add up to cause harm over time. However, it's only useful if it works. And it does work very well. In terms of predicting hypertension, this is data from one of our papers. We can see for HPI, the area under the curve for predicting hypertension 5 minutes in advance is 0.926. As we get further away from the event, the predictive value drops, but that is true for all predictive algorithms. It's not dissimilar to looking at the weather. If we pop our head out of the window in the morning, it's a bright blue sky, we know we don't need an umbrella. Will we need one that evening? Unlikely, but we're not quite as sure. So the further away we are from events, the harder it is to predict. But the algorithm, or HPI, has to have incremental value over what we currently measure. And the first thing to look at is our mean arterial pressure. When we look at changes in mean arterial pressure, it doesn't predict impending hypertension. This is a delta map taken at 3 minutes. We get the very same results if we look at map changes over 20 minutes, a minute, or 5 minutes. The area under the curve is approximately 0.5, 0.55. Just as good at flipping a coin. It may be changes in map or more predictive hypertension depending on how close you are to that hypertensive event. However, in sub-analysis, this doesn't appear to be the case. Changes in mean arterial pressure do not predict hypotension. And when we look at other parameters that we commonly measure, so stroke volume, cardiac output, pulse pressure, heart rate, stroke volume variation, it doesn't matter what you measure, they don't predict hypertension as well as HPI. And that makes sense, because these parameters are single parameters, whereas HPI is a multi-parametric algorithm, taking in all sorts of information from different variables, combining it into a single output, telling us about the likelihood of hypotension. But beyond that, beyond the absolute number, it may be that delta or change in the HPI are just as useful to our clinical treatment. What HPI is doing, or the output doing, is quantifying the process to hypertension. It's looking at cardiovascular or hemodynamic instability. And so changes in the HPI, if the number, for example, is increasing, are suggesting that there's increased instability in the patient. And we can use that to be clinically aware of changes in that patient physiology and to look at the underlying physiology and potential treatments. It's really important to remember, though, at this point, we do not treat HPI. HPI is a warning. Okay, it's telling us of the likelihood of impending hypertension. What we treat is the underlying physiological cause. And there's now work out there. This was published in JAMA a few months ago. And this group used HPI as a warning sign and was shown to decrease the incidence and duration of hypertension without any adverse events, such as hypertension or cardiac arrhythmias. For the next part, I'd like to focus on some new parameters that come with the Acumen software suite to help us treat the underlying cause or understand the underlying cause of hypertension. And the first one is dynamic arterial elastance, or EA-DYNE. Let's take an example of a patient that we see every day. They are hypertensive. We know they're in a preload dependent state because the preload parameters such as SVV or PPV are raised, and therefore we give that patient fluid, which increases the stroke volume, but that has an unknown effect on the blood pressure. And that's because whether increasing stroke volume will increase your blood pressure depends on something called elastance, or in this case, effective arterial elastance. Effective arterial elastance has been proposed as a measure of left ventricular afterload, and it's defined as a slope or the theoretical line through the end diastolic and end systolic points of a pressure volume loop. And therefore, the effective arterial elastance is defined as our end systolic pressure divided by our stroke volume. So why is this a useful physiological parameter? Well, when the aortic valve opens, the left ventricle wants to expel its stroke volume into the aorta, and it's confronted with some afterload or aortic input impedance. The ventricle sees the proximal part of the aorta, which has three main characteristics. It's filled with blood, which needs to be overcome, and so that's inertia. It's pressurized, so we have our end diastolic pressure, so that also has to be overcome. And it also has an elastic wall, the compliance of the large vessels that counteracts further filling. So when our aortic valve opens, the ventricular elastance is coupled to the arterial elastance, and it's good to know if the aortic afterload is relatively stiff, so high elastance, or relatively compliant, or low elastance, because the first case will create extra pressure, and in the second case, extra stroke volume will be absorbed by the large compliance of the vessels. So it's highly elastic, it will create pressure, and vice versa. However, we can't really measure effective arterial elastance, and therefore the concept of a parameter called dynamic arterial elastance has come to the forefront. Dynamic arterial elastance is our pulse pressure variation divided by our stroke volume variation. It's not a measure of arterial load per se, but it defines the dynamic interaction of changes in pulse pressure and stroke volume over a respiratory cycle. A similar analogy is that the preload responsive parameters such as SVV or PPV are not direct measures of preload. They just tell you what part of the pressure of the Starling curve that you're on. It tells you whether a patient is preload responsive. How can we use this in our clinical practice? Well, EA-Dyne allows us to determine if a preload responsive individual, then if we increase stroke volume, will that lead to an increase in pressure? This is a pressure volume curve or relationship for a vessel with a given arterial resistance or afterload. If we look at our stroke volume variation, so a change in volume, if that doesn't generate much change in pressure, so our pulse pressure variation is low, then our dynamic arterial elastance, or EA-Dyne, or PPV over SPV, is 10 over 15 or 0.67. In this patient, if we give them fluid, they will increase their stroke volume because they are preload responsive, but they will not increase their blood pressure. Compared to this patient, who's on the highly elastic part of the pressure volume curve, with the same stroke volume variation, this time the change in volume generates a large change in pressure. So the pulse pressure variation was 25%. So EA-Dyne, or PPV divided by SPV, is 25 over 15, which is 1.67. In this patient, when we give fluid will increase stroke volume because they are preload responsive, and they also increase their blood pressure. So what EA-Dyne tells us, in preload responsive individuals, it tells us whether giving fluid will increase blood pressure or not in that individual. There are a number of studies that have shown EA-Dyne to be a clinically, or to have good clinical utility. This one's from Ignacio Monge Garcia. 25 ICU patients, all whom were hypotensive, so the MAP was less than 65, and they were given a fluid bolus, and they were included into the trial if they increased their SV by 15% or more. He then split them into responders and non-responders, and very simply, the best measurement or the best parameter that told you whether a patient would increase their blood pressure or not was EA-Dyne. And if your EA-Dyne was greater than 0.89, it predicted a 50% mean arterial pressure increase to fluid administration. One important thing to remember, though, is that EA-Dyne is not systemic vascular resistance. It is absolutely or incorporated into the EA dyne, is a measure or a function of afterload, but it is not SVR per se. This is very well highlighted in another study by Ignacio and his group, looking at changes in EA dyne to phenylephrine and to nitroprusside. As you gave nitroprusside, EA dyne increased, and when you gave phenylephrine, EA dyne decreased. So the opposite direction to what you would expect. So really, just to reiterate, EA dyne is not systemic vascular resistance. It's not a number that we chase, accrediting or attributing it to afterload. So what does EA dyne tell us? Well, EA dyne is the interaction of large vessel elastance and our ventricular contractility. It suggests whether a patient who is fluid responsive, and it's really important, you must be a preload responder, whether that individual will also increase their arterial pressure to fluid administration. The optimal cutoff for EA dyne for predicting a rise in mean arterial pressure is about 1, but with all things in life, there is a grey zone, which is about 0.8 to 1.2. And there's also some evidence out there that using EA dyne allows us to titrate vasopressor therapy more effective. We'll have a look at that a bit later on in the virtual animal lab. The second parameter that we can use to try and treat hypertension once preloads have been addressed is contractility. Now, in terms of true physiology, contractility is defined by the slope of the end systolic pressure-volume relationship. If you take an animal model and you occlude the vena cava, so you change preload for a few beats, you get these repeated PP loops, and the line that we draw between the end systolic points is our end systolic pressure-volume relationship, and the slope of that line represents end systolic elastance, which is a measure of our myocardial contractility. But once again, a bit like effective arterial elastance, we can't measure this in our patients at the bedside. And so there are alternative measures of contractility that have been suggested. And one of the alternative measures is the maximal change in pressure over time from a peripheral arterial waveform known as dp/dt max. And it is a surrogate for left ventricular contractility. Now, it's a very large assumption that end systolic elastance is equal to end or left ventricular pressure time changes, which is equal to a peripheral measurement of pressure time changes. And of course, those two things are not the same. But a peripheral measurement of dp/dt correlates with changes in true measurements of left ventricular contractility and changes in the end systolic pressure-volume relationship slope. And we're all used to seeing this in our patients. We have a patient with a good, strong, healthy heart. They have a nice big upstroke generating a high pressure, so dp/dt is high. Whereas patients with a failing heart, they have a sluggish rise on the arterial line. They don't generate quite as high a pressure, and therefore dp/dt is less. And so the function or the utility of this parameter is in trending. It trends, and it trends well towards the measurements of true left ventricular contractility, highlighted by this paper by De Hert from a number of years ago. But importantly, that trending ability is retained when we do interventions or perform interventions to patients, such as passive leg raising, administration of inotropes, or also vasopressors. So that it changes, and the correlation remains the same even when we're performing interventions, gives it good clinical utility in the setting of the ICU or the operating room. There are, however, limitations to arterial dp/dt. It's measured from peripheral artery, and it has only been studied in limited patient populations. Arterial dp/dt underestimates true measurements of left ventricular function, but they do trend in the same direction. And importantly, there are no normal values for arterial dp/dt. It's used as a trending parameter alone. We don't target specific values. And also important to realize it may be affected by other factors apart from contractility. And it needs to be used in caution with people who have severe aortic stenosis, in vasoplegic states, and in patients who are grossly underfilled. So in summary, hypertension is harmful in terms of both kidney and cardiac injury, and hypertension is also prevalent in the perioperative setting. The lower the mean arterial pressure and the longer it's low for, the higher risk of harm to patients. And HPI is a machine learning algorithm that predicts the likelihood of trending towards a hypertensive event up to 15 minutes before it happens. And the additional parameters such as EA-dyne and DPDT assist us in making rationalized treatment choices. Thank you for your time.
Thank you, Simon, for that fantastic presentation. And we have time for a couple of questions via Slido. Again, you can scan the code or go to slido.com, event code HPI, to ask any of your questions. Let's take our first one. So Simon, do you wait for HPI to alarm before treating, or is this a trend that you use as well?
In the early days, Desiree, I think we used it as an absolute number, waiting for it to go over 85 before we treated. But as we became more au fait with technology, we started to understand that changes in the HPI meant there were changes in the physiology of the patient. So as HPI started to increase, that in itself inferred that the patient was becoming more physiologically unstable. Now, there may be no signs on our patient monitors, but the underlying premise of the algorithm means really that's the time to start being aware, to start looking around you to see what the potential causes are, and to look at the underlying physiology and see how that's changing. So yeah, absolutely. The change or the delta HPI is just as important as the absolute number itself.
Yeah, very good. Now, will HPI work on laparoscopic cases? We know there are a lot of limitations with some of the parameters, dynamic parameters.
So open surgery, laparoscopic surgery in the awake patients, the complexities that we have when using it in that situation is, as you described, is trying to decide which patients are preload responsive, because certainly some of our parameters, such as SVV, may need different thresholds to be applied in that setting. But in terms of the algorithm per se, yep, absolutely, works in all sorts of situations.
Great. And will HPI work on patients in positions other than supine?
Absolutely. There's no real limitation. I have to remember that HPI is detecting that underlying instability, the changes that we can detect from the arterial waveform, regardless of situation, regardless of position or type of surgery. What we have to remember is, though, HPI can't predict external events. So if you tip the patient steep head up, or the surgeon takes a clamp off and there's sudden bleeding, HPI can't predict that. It will react to it, but it can't predict.
Yeah, obviously. All right. And why not just use a vasopressor infusion to keep your MAP up greater than 65? We hear this very commonly. You just throw a whiff of some type of vasopressor.
Yeah, that's a really great question. We've got some great footage coming up in the virtual lab where we're going to sort of show how that can be harmful to patients. And ultimately, a bit of low-dose vasopressor in a well-resuscitated patient is no bad thing. However, increasing doses of vasopressor in even mildly hypovolemic patients may have quite profound effects that we can't see. And we'll look at that a lot more closely in the virtual lab coming up later.
Yeah, so it's not one or the one or the either. So now, again, Simon, do you care just to give one more quick summary of HPI and the additional parameters, again, just to solidify some of those big concepts that we've heard today?
Yeah, absolutely, Desiree. So HPI, Hypertension Prediction Index, is a machine learning algorithm. And so the higher the number, the more likely you are to trend towards a hypertensive event, and the shorter the time to that event. And so that alerts us of impending hypertension, but we don't treat HPI. HPI is just telling us there's instability that will lead to hypertension. What we treat is the underlying physiology. And there's some new parameters that we looked at just then. So EA-dyne, dynamic arterial elastance, so PPV over SVV. And that tells us in a preload responsive individual, if I give fluid, will the blood pressure increase? Well, our cutoff value is about 1. And our second parameter is DPDT, so a measure or a surrogate of our left ventricular contractility taken from a peripheral arterial waveform. And so essentially is measuring our ventricular contractility. It's not the same as the true measures, but they trend in the same direction, and therefore it has clinical utility. So the higher the number, the more contractile the heart; the lower the number, the less contractile.